everyone. Welcome. Good to see you all, especially on such a nice day. Finally starting to feel like spring. Welcome and thank you for joining us. My name is Stephanie LaRue. I am the Associate Director at CSREA, the Center for the Study of Race and Ethnicity in America at Brown University. Brown University is located in Providence, Rhode Island, on lands that are within the ancestral homelands of the Narragansett Indian tribe. The Narragansett Indian tribe, whose ancestors stewarded these lands with great care, continues as a sovereign nation today. We commit to working together to honor our past and build our future with truth. CSREA is an interdisciplinary hub that aims to build community with the public and among scholars and students working in race and ethnicity in and around the U.S. We invite you to learn more about our programs and our offerings on our website, www.brown.edu/race. Today's event is a new book talk featuring Tiffany Joseph's Not All In: Race, Immigration, and Healthcare Exclusion in the Age of Obamacare. Dr. Joseph is an Associate Professor of Sociology and International Affairs at Northeastern University. In her talk, Dr. Joseph will delve into the complexities of race, immigration, and the exclusionary dynamics within the American healthcare system, particularly in the context of the Affordable Care Act. This is our final new book talk series event this semester, which aims to highlight new and notable works studying race, ethnicity, and indigeneity that facilitate thought-provoking and critical engagement with engaging scholarship. Our interlocutor this afternoon is Dr. Catherine Thompson, an assistant professor of community health and sciences at Boston University. Her research employs tools from health services research and population health science to demonstrate how macro-level and micro-level health systems are determinants of health inequities. Both Drs. Joseph and Thompson are alums of Brown, so it's nice to have them back on campus. A warm welcome to both of you. For this, for those joining us in person, I will hope you'll join us at the end for a book signing, as well as some refreshments. And for those who are online, well, BYO everything, bring your own. At this time, I'd like to welcome Professor Thompson to the podium to introduce our guest. Thank you.
Thank you, Stephanie. Good afternoon. And yes, it is a beautiful day today. I have the esteemed privilege of introducing our beautiful guest today. Dr. Joseph's research and teaching interests explore race, ethnicity, and migration in the Americas, the influence of immigration on the social construction of race in the United States, immigrants' health and healthcare access, and the impact of policy on people's lives, and the experience of faculty of color in academia. Dr. Joseph's new book, titled Not All In: Race, Immigration, and Healthcare Exclusion in the Age of Obamacare, explores how documentation status, race, and ethnicity influence the healthcare access of immigrants after comprehensive health reform. She's also the author of Race on the Move: Brazilian Migrants and the Global Reconstruction of Race, that examines how U.S. migration transforms Brazilian migrants' understanding of race, racial classification, and racism in the United States and in Brazil after permanently returning. She most recently co-edited Re-examining Identity, Taxation, Racism, and Sexism in the Academy with Laura Hirschfield, who explores how race, gender, and other social identities shape the experiences of faculty of color and women faculty in academia. Her research has been published in various peer-reviewed journals and featured on national media outlets. She has received grants and awards from the Ford Foundation, Institute for Citizens and Scholars, Institute for International Education Fulbright Program, Mellon Mays Undergraduate Fellowship Program, National Institutes of Health, National Science Foundation, and the Robert Wood Johnson Foundation. Dr. Joseph is an assistant professor and graduate program director of sociology and international affairs program at Northeastern University. She completed her PhD in sociology at the University of Michigan and was a Robert Wood Johnson Foundation Health Policy Scholar at Harvard University. Dr. Joseph began her career as an assistant professor of sociology at Stony Brook University from 2013 to 2018. Originally from Memphis, Tennessee, Dr. Joseph is also a graduate of Phillips Academy, Andover, and Brown University. We love our alums. When not working, she enjoys traveling, trying out different fitness classes, and spending time with her family. also on her website, she included a couple of quotes in which kind of inspire her life. And so I definitely wanted to include those. So words that she lives by and she works by: be the change you want to see in the world. Giving up is not an option. The journey of 1,000 miles starts with one footstep. And lastly, all things are working for my good. Please welcome Dr. Joseph.
Good afternoon, everyone. Thank you so much for the invitation to be here. Thank you for the wonderful introduction. It's always a pleasure to come back to Brown, a place that really had a pivotal impact on a lot of the work that I've done as a sociologist. I'm looking in the audience, I see former professors here, and it's always really special for me to come back and to see professors that I had when I was a student here. And I'm not going to say how many years ago that was, because I still can't believe I've been away from Brown for so long at this point. But I do want to go ahead and get started because I do have a lot to cover in terms of talking about this new book, Not All In: Race, Immigration, and Healthcare Exclusion in the Age of Obamacare. So what I want to do is set the scene a little bit for this particular book and why I got interested in this project. One of the reasons that I ended up writing the book, because I was working on a research project over 10 years ago, or that started nearly 10 years ago, really trying to understand the impact of health reform in Massachusetts. When I started this project over a decade ago, the Affordable Care Act had just been signed into law by President Obama, and it was modeled after the Massachusetts health reform, which had been passed into law in the state of Massachusetts in 2006. And so for me, as someone who is a race scholar and an immigration scholar, one of the things that I thought about a lot when I started this project was, if you're an immigrant living in the state of Massachusetts, can you benefit from this great reform, which at that time was getting all of this national attention and being praised as sort of a model for the country, and it had been the model for the Affordable Care Act. And so I just want to start with a couple of quotes from a Dominican immigrant that I interviewed back in 2012 who really praises the Massachusetts healthcare system and her experiences in terms of getting access to health care in Greater Boston. But at the same time, one of the healthcare providers that I interviewed, Greg, really talked about how it's really challenging for him as a doctor to provide care to his immigrant patients because they're bringing all of these various factors with them to their healthcare experience. Notably, he talks about language, discrimination, and how you really have to understand the social context that people are living in order to be able to provide effective health care to them. And so that pretty much became the basis for Not All In, this book that I wrote that had its origins over 10 years ago. And today I'm going to talk a little bit about how racialized legal status, or the intersection of race, ethnicity, and legal status, shape immigrants' healthcare access under health reform. So first of all, I want to start by talking a little bit about what is racialized legal status. Increasingly, immigration and race scholars in the United States have started using this term to really try to encapsulate the ways in which race, ethnicity, and legal status matter for shaping people's lived experiences. So one of the things that's really important to think about is that these two areas of scholarship have often sort of thought about or conceptualized the ways in which race contributes to experiences of discrimination, but also legal status. But until probably the last maybe few years ago, more scholars really started questioning we need to be thinking more about this from an intersectional lens. And so I'm not the person who coined the term racialized legal status. That it was an education scholar in 2011 who came up with the term. But increasingly, sociologists and social scientists have really started identifying and using this term to really try to understand how social stratification happens within this intersectional lens in terms of race and legal status. And so in terms of thinking about the framework that I use for the book and my contribution to this scholarship is really developing a multi-level framework to understand how racialized legal status shapes people's experiences at different levels within the society. And so in terms of thinking about these multiple levels, what I argue is that we have to think about how this plays out at the macro level in terms of how policy making and implementation, because of the history of the United States, that structural racism, a lot of times has been at the basis of shaping the decisions that policymakers are making when they're writing, conceptualizing laws from the very beginning and foundation of the country. But also, too, legal status restrictions have also been a very important part of shaping access to a wide range of benefits in the United States or social services like Medicaid, Social Security, and what have you. And so documentation status and race very much shape the ways that policies get written and also how they get implemented at the macro level. At the meso level, when people, let's say, if you want to sign up for Social Security, oftentimes you might go to a Social Security office, although increasingly, in this current context, a lot of those are being shut down. But at any rate, oftentimes people are having to navigate particular institutions and bureaucracies where they're going to engage with these policies that get implemented. And in these interactions, a lot of times these distinctions based on documentation status and race also play a role in shaping people's ability to engage with these institutions and bureaucracies at the meso level. So really drawing a lot from the work by Victor Ray on racialized organizations, which really argues that within a number of organizations, that even when there are policies in place to try to address issues of racial inequality, that the role of structural racism still is very important in shaping how those organizations function. And then also building on that work in terms of thinking about the world of policy and engagement with institutions, Ray, along with a couple of other scholars, have written about something called administrative burdens. And basically, these are burdens or challenges that people experience anytime they try to engage with these institutions. So if you do want to, let's say, sign up for Medicaid and you have to go there's a process you have to go through to be able to do that. You have to be able to prove you're a resident of the state that you live in and submit documentation proving that. You have to submit proof of income. You have to go through and jump through all of these hoops and what they refer to as these administrative burdens to actually be able to engage with these institutions and benefit from these policies that get passed at the macro level. And then finally, at the micro level, in terms of thinking about people's individual micro level experiences with others, people experience discrimination on the basis of what their perceived race or immigration status is. And increasingly in the US context, oftentimes when people hear the word immigrant, there's often a particular phenotype that they have in mind. Or if people hear the word Latino, oftentimes there's this association around documentation status for an individual. And so that shapes people's experiences of discrimination in their engagement with other people, but also when it comes to things like enforcement, especially, which we're hearing a lot about now in this moment in terms of immigration enforcement, but also law enforcement in terms of how people are perceived by law enforcement and immigration enforcement officials and how that can really shape their experiences as well. I do want to briefly mention the role of language access here in terms of thinking about at the micro level as well, because one of the things that I found in my research and that I'll talk about more in the talk is that increasingly language plays a role in racializing individuals. So even if someone might, let's say, look like they are a US citizen or they are an American, oftentimes if that person speaks English with an accent or they have limited English proficiency, this can then result in racial discrimination from others. And so increasingly, we're starting to see language being used as a way to determine or for people to make determinations about who belongs or who doesn't within the US context. And so that's something that's also really important. And then the other thing that I'll just mention here too, the role of citizenship in the United States has not been experienced equally by people. So throughout US history, race, gender, social class, sexual orientation, and the list goes on have really shaped people's experiences of citizenship. And so what that means is that even if you are recognized as a legal US citizen, you might not be treated as though you fully belong within the society. And so this is really important as well in terms of thinking about people's lived experiences at the micro level and how racialized legal status might shape them or shape their experiences. Really briefly here, this is the framework in terms of a figure that I developed that I have in the book to make it a little bit easier to try to sort of encapsulate what I mean by racialized legal status playing out at these different levels. And so I won't go into as much detail here because I just sort of walk through or talk through the framework, but I'll just really mention here too in terms of thinking about, again, at the macro level, even in terms of thinking about the policymaking process, race and documentation status categories are often determined by the U.S. government in terms of shaping who's able to get access to the United States, immigrate to the United States, remain within the United States, and what have you. And how this plays a role in really shaping resource allocation in terms of the ways in which public policies get written and legislated oftentimes is stratified based on these categories that have been created by the U.S. government. And so here I just have different policy areas where the racialized legal status framework plays out in terms of thinking about these categories and restrictions that often exist within existing policy, healthcare, immigration, and what have you. And I have them overlapping with each other because a lot of times these policy domains intersect with each other. And so, for instance, my focus in this talk today on immigration and healthcare, oftentimes the healthcare benefits that people are eligible for are very much shaped by their documentation status. Your immigration status or documentation status can also shape your ability to get a driver's license. The Real ID is going to be implemented, or I think that process for the Real ID, that policy is going to be enacted in May. And so again, another example of how your documentation status can shape your ability to have access to particular government identification and what have you, increasingly important. I'll just briefly mention here that in terms of thinking about the racialized legal status framework with regard to documentation status, there is undocumented at one end of this continuum all the way up to citizen. And also in terms of the history of the United States with regard to race, people of color or non-white individuals at this side of the continuum, and at this side, individuals who are racialized as white. And the reason I have these distinctions set up this way is because what I really want to demonstrate is that between undocumented and citizen and non-white and white, there are a wide range of categories that exist. And also, too, where people are within this continuum very much shapes their experiences in U.S. society in terms of, again, the types of benefits that they can get access to because of policy, but also, too, in terms of issues of deportability, which I'll talk about briefly in the next slide as well. And all of these, where people are based in terms of racialized legal status, can also have an impact on the wide range of outcomes that people might experience within the U.S. based on what their racialized legal status is. In the background here, these diagonal lines going through the background represent structural and systemic racism, basically in terms of demonstrating how within our society, these features of structural and systemic racism are always sort of constantly operating in terms of thinking about this framework and with regard to racialized legal status. On this next picture here, this is really a way to show how this might happen more at the individual level for people. And whenever I explain this and when I give this talk, but also in the book, the example that I use or try to tell people to think about is, for instance, in New York City, they used to have stop and frisk. So, you would be more or less likely to be stopped in the subway station based on what your perceived race was. And so here, this particular figure works in the same way, where across the x-axis, it's like documentation status, a wide range of categories of some of the most common ones that exist, with undocumented people, again, historically being more vulnerable to deportation, but increasingly we're seeing pretty much anyone just about in this list now being even more vulnerable to deportation. And in terms of usually the case has been that U.S.-born citizens, at least when I was writing and conceptualizing the book, were at least vulnerable to deportation, but a lot has changed since I made the final revisions and edits to the book before it came out and I sent it to the press. And in this axis here, the y-axis, this sort of represents in terms of people at the top who are least racialized in the United States. And historically, that's been individuals who are racialized as white or maybe have lighter skin tone. And most racialized has typically been people who are racialized as Black or maybe have darker skin tone. I didn't try to use actual specific racial and ethnic categories in this continuum here because I think depending on the particular time and the context in which we are living, people's experiences of racialization and where they might fall here could shift and differ. And again, I feel like we're in a moment where some of this is being reconfigured. But at any rate, if you are, let's say, in a subway station in New York City, and let's say ICE or the police, NYPD, are doing security checks and wanting to determine who they're going to stop, the group that would least likely to be stopped are individuals who are perceived or racialized as white. But if they are stopped, once it's determined that they're a citizen, they'll most likely be released to go on their way. If it is an individual that's racialized and white and is undocumented, they would be least likely to be initially stopped, but most likely to be deported because of their immigration status. And if we move down the continuum to this quadrant, if you are racialized as Black or a darker skinned immigrant, you would be more likely to be stopped and deported once it's determined that you don't have papers to be here, although, as I said, we're in this moment now where you can have papers and still be detained and deported, even by accident or by mistake. And if you are a U.S.-born citizen who's stopped, you're more likely to be stopped, but least likely to be deported. Again, I feel like I have a lot of caveats now because there's just been so many developments within the last month or so that, again, in terms of thinking about the configuration of how racialized legal status plays out or how it has typically played out or shifting in this moment as we speak. So what I want to do is point out a little bit how racialized legal status mattered for shaping the healthcare experiences of the different groups, immigrant groups that I interviewed in Greater Boston for over a decade. Basically, what I did for this project was I did 3 rounds of interviews at 3 particular time periods that coincided with major policy shifts. I started the study in 2012 to 2013 under what was then the Massachusetts Health Reform, which had been implemented in 2006 and had been in place for about 6 years at that point when I started the project. In 2015 to 2016, I did another round of interviews because I wanted to understand, after the ACA was implemented, what was the impact on how healthcare access was reconfigured in Massachusetts, and particularly Greater Boston, for immigrant communities there. And then lastly, I did a final round of data collection in 2019, which coincided with the first Trump administration, and also at that time, similar to now, lots of sort of haphazard executive orders, immigration policy proposals, and things on the ground, but also that coincided when there was an attempt to repeal and replace Obamacare. So again, lots of major policy shifts were happening as I was doing the research. And I interviewed 3 different stakeholder groups. The biggest group of people that I interviewed were immigrants, Latin American immigrants, particularly in Greater Boston, who were some of the largest immigrant groups there. And I focused on Brazilians, Dominicans, and Salvadorans because those are 3 of the largest groups. They're from different parts of Latin America. They're racialized differently. Brazilians tend to be racialized as white, Dominicans as Black, and Salvadorans in the middle as Latino. And also these groups have different documentation statuses. Brazilian immigrants tend to come to the United States with tourist visas and overstay them, which is how they become undocumented. Dominican immigrants tend to be green card holders or naturalized U.S. citizens. And then Salvadorans tend to be undocumented, but some of them are also eligible for temporary protected status, which is a precarious legal status that it protects you from deportation, but it doesn't provide a pathway to citizenship. And so these groups were ideal for really trying to understand how race, ethnicity, and documentation status shape their experiences. I also interviewed healthcare providers who primarily worked with immigrant patients, so physicians, medical interpreters, social workers. And then lastly, I also interviewed a wide range of employees from immigrant and health advocacy organizations to better understand the social context of what was happening in Greater Boston alongside these other shifts in health policy that I was really interested in exploring in the study. So I can talk more about the Q&A. I can talk more about the methods in the Q&A if you would like, but I do want to go ahead and get into some of the findings. And what I do want to emphasize here is that the findings that I present today are from the last year of the study when I did interviews in 2019 under the first Trump administration, because I feel that there is a lot from that moment that reflects this current moment that we're in. Although certainly when I was writing or doing the research, I didn't anticipate that we would be living under a second Trump administration. And so here I just want to start with a quote from one of the healthcare advocates that I interviewed in 2019, who basically talked about how difficult doing his job was, trying to connect immigrants and other and citizens of the Commonwealth with healthcare access in 2019. And basically he says, dealing with this administration every single day is a challenge. There is something new and it's like a bomb. And he basically says that immigrant communities don't know what to react or how to do because everything that's happening really instills fear in them. And so I think it's really important in terms of thinking about Daniel's quote, because I feel like it reflects so much of where we are in this moment. And in the Q&A and maybe some of the questions that I'll get, I'll be happy to talk a little bit about how I feel like this moment we're in is different from the moment when I actually did the research. But in terms of thinking about how racialized legal status plays out at the macro level and the ways in which government perpetuates both structural racism and anti-immigrant discrimination through laws and policies at the federal and subnational level, Joshua, a health advocate that I interviewed in 2019, really talked about or singled out a particular policy in terms of public charge, during which this particular time the Trump administration was proposing to change public charge policy, which has existed in immigration policy for over a century, but the Trump administration was basically proposing to change it to make it much more difficult for lower income individuals to be able to get green cards to come to the United States. And so Joshua essentially talks about how there is a very clear connection to race and the racialization of these policies in terms of how it will have an impact on the populations of immigrants or people living in the United States or trying to come to the United States as immigrants. And he says, one piece of this has to be the history of these policies throughout time. Public charge policies that existed for over 100 years, we so clearly see that in the present, it's so focused on people from Mexico, Central America, South America, and the Middle East, typically people who are not racialized as white. And there's this deeply embedded aspect of this policy, there's this racialized element. And he says what's tricky about this is that it's not necessarily facially racist. It's not explicitly racist. But again, the association that people make between immigration and race plays a role in shaping the way that public charge policy, at least under the Trump administration at that time, was being applied so that it would very negatively have an impact on immigrants of color specifically. And so he really talks about, again, sort of this intersection of structural racism directly embedded in U.S. immigration policy. Another example here I have from another advocate that I interviewed in 2019, where he basically talks about people were actually starting to disenroll themselves from public benefits or social services that were funded by the government because they were afraid that if their names were on the rolls for any of these programs, that could be used as a basis to target them and then for them to be detained and deported. And again, in terms of thinking about this role of sort of federal restrictions or documentation status restrictions and access to public benefits, but also, again, the stigma or this perception that it's people of color who are getting access to these benefits from the government, also playing a role in shaping the ways in which people are responding to these particular policy changes that are happening at the macro level. Moving on to the meso level in terms of when people engage with institutions and bureaucracies, one of the things I found in my research was that a lot of the burdens, administrative burdens associated with racialized legal status often make it harder for people of color and especially immigrants of color to apply for health coverage and also obtain health care, engage with providers, and also the role of language access. So one of the immigrants that I interviewed who was a naturalized citizen in 2019 basically talked about how during the first Trump administration that a lot of immigrants and people of other nationalities were afraid to go to hospitals and again engage with the meso level because of the climate around what was happening in terms of policy. And there was a perception that if you received medical help, again, that would be an impediment to you being able to update or change your status if you were in the process of trying to become a citizen or get a green card. There was this fear that if your name was on the rolls for any of these programs or if you got health care, that would be a disadvantage for you. The way that language came up in the study was also, too, in terms of thinking about either access to medical interpretation or people talking about their experiences of discrimination when they either didn't speak English well or spoke it with an accent. And this particular quote from Josefina, a Dominican advocate I interviewed, basically said, oh, we don't like or deal with Latinos here. So that's sort of the perception or idea in terms of when people try to engage with the meso level, particularly healthcare facilities, that there is a stigma for Latinos. And she says you can't find someone who speaks Spanish, and they don't try to find anyone who does the interpretation because from her perspective, they don't want Hispanics here. And she says, at least that's the message that we receive: learn English or leave. And so this is an example in a way in which language plays a role in racializing individuals, but also negatively affecting people's ability to get the care that they need or even to be able to apply for coverage, particularly if the documents that you need or the paperwork that you need to fill out is only in English and you don't know where to get assistance in other languages. And then to move on to the micro level in terms of thinking about the discrimination that people experience in their individual lives, either when they're walking down the street and engaging with other people or in healthcare facilities. I just have a couple of quotes here that one point out the role of language. And so Magdalena, a green card holder from El Salvador that I interviewed, basically talked about when she was trying to get help through customer service. She tried to get help in Spanish. She was told there was no help available, but when she called in English, she didn't have any problems. And so again, the role of language really playing a role in shaping the ways in which racialized legal status shape people's experiences. And then Gloria, a BHC provider one of the providers that I interviewed from the Boston Health Coalition, for the study, basically talked about how the climate or the socio-political climate under the first Trump administration was making her Latinx patients feel more unsafe in terms of society, largely due to the quality of the language that they speak and their race. And she says now there is freedom to basically express anti-immigrant racist rhetoric if someone's not speaking English or speaking with an accent, for people to be targeted, that she found that with a lot of her patients that was their experience. And so the other thing that I just want to mention too is at the micro level, something else that came out quite a bit in my interviews in 2019 was that a number of the providers that I interviewed and the advocates talked more about how their own identities or their own racialized legal status was also shaping their ability to do their work into just their lived experiences. So Cecilia, one of the providers that I interviewed, talked about how she was just walking down the street in Boston and a white woman just threw coffee at her and said, "Go back to your country." And Cecilia was like, I was just speechless. I couldn't believe that had happened to me. And so increasingly I found that providers and advocates like Cecilia and Sebastian that I interviewed talked quite a bit about how in their everyday lives they felt like the fact that they were from Central America or South America or racialized not as American, even though both of them were both U.S. citizens, really spoke to the ways in which immigration status and particularly citizenship and the experience of it is racialized in the United States, and how being recognized as a legal citizen of the United States does not protect you from the type of discrimination that Cecilia and Sebastian and some of the immigrants that I interviewed talked about experiencing, that particularly in 2019 felt very, very heightened and much more explicit. I just want to talk briefly about healthcare implications at this particular time when I was doing the research before I get ready to conclude and for us to have some discussion around the book. But one of the quotes from the book that I did with Javier here is one that really, really stuck out to me because I did this interview with him in November 2019. And so he says, before the Trump administration, the health centers were full of people seeking services. And when things started to unfold in the presidency, the health center was empty. Nobody was coming. And he really talks about the importance of why it's important that immigrants feel safe going to healthcare facilities, taking their kids to get vaccinated, get preventive health services, because he said if we have any type of dip of that nature, it can have a ripple effect on broader public health. And so this was right before COVID happened. I wrapped up my interviews right before COVID happened. And when COVID started unfolding in Greater Boston, I just kept thinking about this interview with Javier over and over again, because the communities where I did most of my research for the book were some of the hardest hit in Massachusetts and in Greater Boston in terms of COVID cases, deaths from COVID, and what have you. Really speaking to sort of this impact around concerns around public health if people don't feel safe getting healthcare services. The other thing that I just want to mention too is another Brazilian advocate that I interviewed basically said that people were experiencing a high level of stress and anxiety, and that she basically said, I think that immigrants are living in a situation with extreme instability, a situation of terror. For emphasis, she said, I think that's the appropriate word, terror. And how all of this really played a role in shaping people's health outcomes in terms of mental health. But also, too, Madeline, a healthcare provider that I interviewed, talked about even people who are documented and are citizens are feeling the mental health effects of the stuff that is going on in terms of the stigma and all of the sort of anti-immigrant rhetoric, racialized rhetoric, and this rage against immigrants of color that was coming out of the White House, but also proliferating across the country in response to what was coming out of the White House. Another immigrant advocate said that I think our mental health has been under siege, mentally attacked, and not just for the immigrant communities, but anyone working in that space trying to help immigrants in the grassroots, nonprofit sector, and what have you. She says it's like we're under attack. And so I'll just conclude by briefly talking about Kevin, this healthcare provider that I interviewed over the course of the study, and in 2019, who basically said that in terms of thinking about the impact of comprehensive health reform for his perspective as a provider, he basically talked about how he feels like, and when I interviewed him in 2019, he thought that people had worse access to health care under the Affordable Care Act than they did when he started practicing as a physician prior to 2006, and that's basically what he says here, especially for undocumented immigrants. Over time, he felt like a lot of the changes that were made incrementally in state policy and health policy with documentation status restrictions meant that a lot of his immigrant patients either weren't eligible for the cutoffs after they happened, or it just became a lot more difficult for people to be able to navigate the system. And so much of this is related to people's documentation status, but also some of the barriers that people experience that are associated with their racialized legal status. So the issues around language, concerns about being afraid to go to the doctor because if there's an immigration raid in your community the night before, you're gonna be afraid to go the day after. But also, too, in terms of concerns about profiling, people would be afraid if they were at the T station and they saw cops or anyone in a uniform, they were afraid that they might get stopped because they knew they would be racialized as an immigrant, and then that also shaped people's healthcare experiences. So to get ready to conclude, I just want to briefly say that in this particular moment in terms of thinking about broader implications, that restrictive federal policies can really undermine inclusive subnational policies. And so we're living that out at this moment in terms of thinking about, what's happening in terms of this attempt to use federal funding to really get blue states particularly to sort of get in line and work with the administration. We're also seeing this tactic work. We're in higher education. We're definitely sort of living that as well, and how this really plays a role in shaping people's ability to get access to particular services and things that they need from the government. Again, in this moment, many of those services seem to be on the chopping block. And we can talk more about that in the Q&A. The other thing that I want to point out that I think is particularly important in this moment is that marginalized citizens are also negatively affected because of racialized legal status. So I interviewed a number of naturalized citizens in the immigrant sample, and many of them would say things like, even though I'm a U.S. citizen now, I don't feel like I'll ever be fully treated or regarded as an American because I'm not white. And so this is, something that has often been a part, throughout U.S. history, this notion of citizenship being experienced very differently depending on what your demographic group is. And that is something that is really important in this moment as well. And in terms of thinking about this framework for racialized legal status, I particularly apply to the healthcare area realm within this book, but I argue that it could be extended to areas beyond healthcare access and health policy and shape people's lives in multifaceted ways. And so it's really important to really think about how these intersections in terms of social inequality function for individuals and shape their experiences in various ways. So I will get ready to stop there, and I look forward to our conversation. And thank you so much for the opportunity to be here.
Thank you for that. I was very excited for this conversation this week because I was like, ooh, something that aligns with my research and stuff that I'm interested in. And I think a conversation that is much needed in this current climate for individuals to have discourse and just kind of talk about.
Mm-hmm.
So in true academic form, I have plenty of questions here prepared for Dr. Joseph that I will just ask in succession, and then we will open it up to the audience for questions that they're interested in. How does that sound? Does that sound great? And then, okay. So one thing that I'm very interested in, I'm always interested in the researcher behind the work. So I had a couple of questions that, talked about you as just a person.
Mm-hmm.
So what initially drew you into the intersection or studying the intersection of race, immigration, and healthcare policy? Was there a particular moment or story that sparked your journey or in this work?
Absolutely. Even though I did the research for this book in Greater Boston, the idea for the project or the seeds were planted when I was doing research for my dissertation in this small town in Brazil called Governador Valadares. Mm-hmm. And I was doing research for my dissertation looking at how immigrating to the U.S. changes how Brazilian immigrants think about race. And then when they go back to Brazil, how does living in the U.S. transform their understanding of race relations there? Mm-hmm. And in a number of my interviews with returned migrants, the issue of health kept coming up in my interviews, even though I wasn't asking about it. So people would say things like, when I lived in the U.S., I couldn't get access to health care, or I was working really long hours, I wasn't getting enough sleep, I started having health problems, and I had challenges trying to navigate the U.S. healthcare system. Mm-hmm. I even interviewed a couple of people that basically said that they developed some pretty chronic health conditions in the United States, and they returned to Brazil earlier than they had intended to because they needed healthcare, and they thought they would get better access to care in Brazil than in the United States. And so that really stuck with me, through finishing up that dissertation research, coming back to the U.S., writing the dissertation, finishing grad school, and starting this postdoc. And when I started my postdoc with the Robert Wood Johnson Foundation, I thought that this might be an important time to try to look at that particular relationship. What is it about being an immigrant and some of the challenges that people mention shaping their healthcare access, and wanting to delve into that a little bit more. And in terms of the timing of it, with, the ACA had just been signed into law but not yet implemented, I thought this would be a great opportunity to try to understand more about the Massachusetts health reform, which was in place at that point, and trying to understand, if you're an immigrant living in the state of Massachusetts, can you benefit from this reform that's getting all of this national attention at that time? And so that's really where the seeds of the project started, that in terms of wanting to learn more about the relationship between documentation status and healthcare access. And just being in Greater Boston at that particular time was really ideal. There's a large Brazilian immigrant population in Boston, and that was helpful to me in doing the research. I don't know if you're going to have questions about the methods or whatnot. But that was really helpful as well in terms of being able to connect with the Brazilian immigrant community, and also too really wanting to think about sort of the role or the ways in which Brazilians are racialized in their experiences, and then also Dominicans, another large immigrant group, and Salvadorans. Those are three of the largest immigrant groups in Greater Boston. Oftentimes people think about the Latino label as sort of a heterogeneous one. And I was really interested in wanting to understand those differences and how they played out in shaping people's experiences with the healthcare system.
Yes, and Boston, Massachusetts, like you said, is an ideal setting in order to explore multiple identities. And so when I saw that it was taking place in Massachusetts, I was like, oh, that's right down the street from us. And that's actually a place in which I work. And so you know so much about your own community, but I think your book highlighted things that a lot of people either overlook or they don't dive too much into. And so your book definitely filled a part for me where it's just like, I knew a lot, but I didn't know quite that much. And so that was really great. I also kind of want to touch on something you just mentioned. So one really powerful element of your book was talking about, exploring the racialization among immigrants, many racialized as Black in the United States. So how did your own identity as a Black woman influence your conversation with respondents about racial identity and experiences with discrimination in the healthcare system?
Absolutely. So I'm originally from Memphis. I identify as African American. And so I don't share, I guess, the heritage or background of the immigrant communities that I was doing research with. But the fact that I had lived in Brazil and spent quite a bit of time there. I spoke Portuguese, I speak Spanish. When I was in college here at Brown, I studied abroad in the Dominican Republic. Yes. And so those experiences were really pivotal in me even starting to sort of these ideas that I started developing about race as a junior scholar, starting as an undergrad at Brown and then going to graduate school. Were really foundational in terms of thinking about ideas about race, how ideas about race are different based on what country you're in, how physical features in one country in the U.S. might be racialized as Black, in Brazil or the Dominican Republic or South Africa, it could be very different. And my own experiences having traveled to those places, depending on how I was wearing my hair, what language I was speaking, oftentimes I was racialized or people thought I was Brazilian or Dominican. And oftentimes I wasn't racialized as Black in those contexts. So when I've been to South Africa, people would tell me I was colored. When I was in the Dominican Republic, people are like, oh, you're Morena, you're not Black, don't call yourself Black. What are you talking about? And the same thing in Brazil. So in terms of even thinking about being in the same body, but traveling to different contexts, and how I was racialized and thought about differently in those contexts was something that I think has really been at the key of a lot of the work that I've tried to do as a sociologist, really understanding how race is a social construction that depending on what context you're in, it can function very differently in terms of racial classification, whether racism is explicit or implicit, its associations with social class, and can money widen, which is thought to be the case in Latin American contexts. And so all of those things I brought with me to this particular project in terms of thinking about the research questions, but also thinking about the communities that I was doing research with, and oftentimes being able to share those experiences and say, oh, yep, I speak Portuguese. I lived in Governador Valadares and Minas Gerais. Many Brazilian immigrants in Greater Boston are from that area of Brazil. So that was already a way that I was able to connect with people because they're like, oh my goodness, you're an American and you know where I'm from and you spent time there and what have you. And similar to the time that I had spent in the Dominican Republic. So those were things that I would say are aspects of my identity that very much shaped the work. And also, too, I write about this in the book. I'm originally from Memphis. I'm only one generation removed from Jim Crow segregation. Both of my parents grew up going to segregated schools. So the opportunities that I've had, their life experiences have been vastly different from the opportunities that I've had access to. And so that's something that I've constantly reflected on in terms of thinking about the opportunities that I've had, but also how exclusion plays out and is directed towards U.S. citizens, which has been the case for African Americans and other groups of marginalized citizens for much of U.S. history. And so those are the sorts of things that I was constantly thinking about, as I was doing the research, but also as I was gauging with these communities. Even though my positionality is different, these were some of the common threads and parallels in terms of lived experiences that helped me to be able to think more about what must it be like to be sick in the healthcare system and not be able to communicate with your provider, or to be told that you're ineligible for this because your documentation status is X. So those were things about in terms of thinking about my identity, those sort of parallel experiences that shaped a lot of the work for me.
Yes, and it also helped you build trust and transparency with, because, they're inviting you in their spaces, and you're having some very vulnerable conversations. And sometimes it could be a little, just like, oh, let's talk about X, Y, and Z. And they're like, who are you?
Yeah, exactly.
Who are you? Exactly. And so I know that you talked about in your book about your multilingual skills playing a really critical role. Do you mind expand? I know you just touched on it, but you can expand on it a little bit more. Just being able to meet individuals where they are.
Yes, for me, I think that's very important in terms of doing the research and being able to communicate with the communities that you're doing research with.
It's important.
Very important, especially talking about topics like race, immigration, again, these topics that are very vulnerable, can be very controversial, and it helps to be able to do that without an interpreter or a translator. And so it really allowed me to be able to connect with people in a way that I think I might not have been able to if, I didn't speak those languages, but also too, in terms of thinking about some of the nuances in terms of things being lost in translation. Even for the book, when I was analyzing the data, I analyzed the interviews in the languages in which they were conducted. And so the quotes that you see in the book are the English, I only, translated quotes from the research that I use in the book or in other publications. And that was a very deliberate decision too, because I wanted to be very careful with issues of language and making sure I was getting the nuances when I was analyzing the data too.
All right. You had mentioned positionality in one of your last answers. I kind of want to touch on immigrant stories of exclusion and suffering and carrying a significant emotional weight. And there was a story within your book where you were giving an interview with one of your participants, and you had seen that this participant was grappling with a lot of mental health issues and was saying how he was depressed. So I was wondering about your position, especially as a researcher. And I know that you even put some of your own dialogue in there of like, did I have to step out of my role as a researcher because I'm also human and I want to give this individual resources in order for them to, be able to take from this interview and be able to, address or be able to receive help for their mental health. Can you mind speaking about that?
Sure. So that was an interview that I did with a Brazilian immigrant who was undocumented, who was really talking about the challenges of living in the U.S., not only because he was undocumented, but also because he really missed his family at home. And he'd also, at that particular time we were doing the interview, was starting to feel like particular policies in Massachusetts that made it seem like it was more immigrant friendly, that those policies were starting to shift and make it more difficult for people like him, for instance, to get driver's licenses and things like that. And so he really was grappling with, given everything that's happening in the US, should I stay or should I go? And that was sort of the dilemma that he was talking through in our interview. And, he just kept using these words in Portuguese around stress and anxiety and, depression. And, in that moment as an interviewer, I was just sort of like, okay, I feel like some red flags are going off here. I don't want to interrupt him telling his story, but maybe after we get to a good pause point or after the interview is over, I can try to connect him with some resources. And so as a result of, doing this research, with healthcare providers, I knew with providers and advocacy organizations, I sort of knew who I could point him to or put him in touch with, because I was doing research not only with immigrants, but with this wide range of people. And so I felt really fortunate that I was doing the research in a place where there were resources available, although navigating them could be very difficult too, which I also write about in the book.
Yes. And with that, you really argue effectively that having health insurance doesn't automatically translate to meaningful healthcare access, especially for immigrant populations, and how Massachusetts was initially a beacon of progressive health reform, and how before the ACA narrowed inclusivity for immigrants. Given this paradox and the outcomes that you really talked about, what do you think health reform advocates misunderstood or overlooked when it came to a lot of dynamics when it came to the immigrant population?
Yes, so it's really interesting that you asked that question, and I write about this a little bit in the book, that in terms of in 2006, when the reform was being debated, the Massachusetts health reform under then Governor Mitt Romney. Again, that feels like a lifetime ago. But at any rate, one of the things that I learned from some of my interviews with immigrant advocates and health advocates was that the state, they did want to include, or legislators wanted to make sure that anyone living in Massachusetts, regardless of documentation status, would be eligible for some type of coverage, but they didn't want that to be publicized. So there were concerns about how if this gets out in the media or wind of this, that this could derail Massachusetts health reform efforts. Yeah. So it was sort of slid in very quietly, that inclusion around eligibility for anyone who's income eligible regardless of documentation status. So I think that, even from the very beginning, in terms of what I just told you, that Massachusetts legislators were aware, or felt that even in 2006, that could be sort of politically explosive to publicize something like that. But they still made the decision to do it. And Massachusetts became the first state to have that sort of a reform where everyone was included. Sorry about that. Where everyone was at least eligible to apply for coverage. But at the same time, I don't think that legislators anticipated, or maybe they did, that, the process of applying for coverage can be very cumbersome as well. Yes. So just in terms of, at least when I started the study, this was before everything was online, you would print out the form. The font was like this tiny, you could barely read it. It was in English. You had to fill it out, mail it to the state health department. You would also have to put in your documentation, so in their proof of residence, proof that you're a resident of Massachusetts, proof of your income. But even right there, those two things, if you're an undocumented immigrant and you share, if you're living with other people and you don't have your name on a lease or a utility bill, you can't get a license if you're undocumented. You don't have proof to be able to demonstrate that you're a resident of the state. At the same time, proof of income. If you're being paid in cash, it's hard to establish proof of income. And those are two things that you really needed in order to be able to apply for coverage, to determine what coverage options the state had that you were eligible for. And so these are ways in which people were bureaucratically, what researchers refer to as bureaucratic disentitlement. You're eligible to apply for things, but because the process is so difficult, you have all these administrative burdens, you might as well not even be able to apply. And so I think that was probably one of the ways that I think maybe legislators probably didn't anticipate, or again, maybe they could have, I don't know, what was, in terms of the process of them deliberating on the reform. But yeah, in terms of that being a way that people, I think, were excluded, and the language piece as well, in terms of most of the paperwork was available in English. Now with more technology, it certainly helps. And, we have AI. And so a lot of these websites, you can, do an automatic translation. But if you don't have computer literacy, or if you don't have a stable Wi-Fi connection, that's also a challenge. So there are also these other issues, and I think barriers that get in the way that I think legislators might not be aware of. Again, when they're deliberating in this policymaking process, and implementation process, there are certain populations that they're probably not thinking about, probably because many of the legislators don't share the demographic backgrounds of some of these populations. So they're not thinking about that because it's not something that would affect them.
Yes, and throwing up additional barriers. I know one part of your book you had talked about how a lot of individuals were eligible for coverage, but you had to go through the process of applying first before it could funnel you into like the health safety net or Mass Health or coverage under the Commonwealth in Massachusetts. But you have to do that first step.
That's
first.
right. That's the first step. Yes. So again, as I said, that process was very cumbersome. And then the next step is you usually would get a letter or some sort of notification from the state government saying, oh, you're eligible for this particular program. And then the next step is you've got to identify a primary care physician or find one. And so that's the next step that's very challenging. I don't know how many people in this room have tried to find a new primary care physician and how long it takes to wait to be able to get a medical appointment. But that's not easy either. And primary care physicians are often the entry point to the U.S. healthcare system for most health insurance programs. Exactly.
Yes.
So if you can't identify a primary care physician, let's say if you are on Medicaid and providers can opt out of seeing Medicaid patients because of the low reimbursement rates, then there's again another sort of barrier to getting, you have coverage, but can you find a provider that accepts it? And then can you find a provider where they have medical interpretation services available if English is not your first language? So again, every step of the way, applying for coverage, trying to find a provider, and then actually navigate the system is a challenge for most of us in this room. But imagine if you can't communicate with people effectively, you have all of these other things getting in the way of that, it becomes even more of a challenge.
Oh, I'm sometimes I don't even like to admit that I went through, my mom was a nurse and I went through her for most of, making appointments or getting recommendations on what I should do, even navigating the healthcare system as a health services research PhD candidate or student when I was back then. So I can't even imagine. I also see that for a lot of the individuals that I work with in the pregnant and postpartum individuals in Medicaid, just the barriers that are thrown up. So you describe challenging dynamics immigrants face, wanting visibility to access resources, but also needing invisibility to also remain safe, especially under harsh immigration enforcement. And you really push this home in Chapter 4. How do you think policymakers and healthcare systems, especially in the state of Massachusetts, balance these tensions of visibility and vulnerability, even if they do?
I mean, it's a challenge, and especially in this moment. Earlier this morning, I was reading this op-ed that was written by a healthcare provider and a health advocate. Actually, a couple of them I interviewed for the book. And it was basically about how can healthcare providers in this climate try to make sure that immigrant patients feel safe in getting care. And so it had maybe about 7 or 8 things on that list. And so these were things that were not related to policy, but I would say probably in response to the policy climate that we're in terms of, having Know Your Rights campaigns and making it clear to people these are what your rights are in healthcare facilities, which under, the first Trump administration, ICE officials were not allowed to go into what were deemed sensitive locations, so places of worship, hospitals, and schools. And President Trump signed an executive order basically ending that. So it's basically anywhere they can go and capture people, they are doing that now. Yes. And so this op-ed was really about, even in healthcare facilities, trying to make it very clear that this is sort of a private part of the facility where ICE cannot be. So it had strategies for thinking about how to do that. And you asked about legislators. And I feel like in this moment, I'm not sure that there's a lot that legislators can do. Yes. It's really about how people on the ground, a lot of the advocates, some of the people that I interviewed, the organizations, the work that advocates across the country, healthcare providers and others working with these communities are doing now is just be as informed as you can and do the best that you can, because we really can't rely on our lawmakers to be there for us. And even in Massachusetts, I would say that because of what's been happening at the federal level around these threats to restrict funding, again, it really affects what state legislators can do in this very sort of narrow line that I feel particularly Democratic governors have to play in this moment of wanting to advocate for their states, but also wanting to call out the federal administration when it is doing these things that are very egregious.
Yes.
And it's a hard line
Yes, and you
for
also
them to toe.
and you see that conflict between like state legislator and maybe like some laws that are passed at the state level and then federal regulation as well.
Exactly. Or either sort of federal regulations that used to exist, those now no longer being in place and allowing again at the state level, there can be those restrictions, create this sort of conflict and this tension between what's happening at the federal level and the state level. And the people on the ground are the ones who are caught in the crosshairs every day, residents and citizens and people who live. Exactly. We're the ones who are dealing with the consequences of these macro level policies that are getting passed by our legislators at these various levels of government. We're the ones feeling the impact of it.
How the policy's actually playing itself out on the ground.
Exactly.
In our lives.
Exactly. And that was sort of my goal with the book, to really be able to show on the ground as immigrants are trying to navigate the healthcare system under these reforms that were theoretically supposed to extend access to care and to coverage, or to coverage and to care. It actually did the opposite. And that's one of the major findings of the book, that I find that healthcare access actually got worse for this segment of the population under these policies that were supposed to extend access to coverage.
Yes, just
because of the barriers that we talked about.
Yes. So I'm going to ask one more question, and I'm going to open it up to those those in the audience and also those on Zoom. So I know this is a loaded question, so bear with me. But your book discusses how Trump's first presidency impacted immigrant communities. Now that Trump has returned to office, as I saw you had Trump 1.0, Trump 2.0, what parallels or escalations do you foresee, and how can communities and advocates respond effectively in order to protect our communities?
That is a very loaded,
more
so difficult question. I feel like that I feel equipped to answer, just because I feel like everything is changing.
It is
so
daily.
Quickly. I mean, every hour I'm getting like a breaking news email alert about something else that's happening. I would say that in terms of parallels between this moment and 2019, when I did the last round of data collection for the project, the sort of haphazard policies that were put into place, everything happening really quickly, then things, either, legal challenges, mounting lawsuits around those policies and things basically being put into effect. I feel like that's pretty similar. Where I would say the difference is this time around is that, and I was reading about this in, I guess, one of the newspaper articles I was reading earlier today, but how essentially there are just no guardrails this time. And for me, that feels a lot scarier.
And also the speed in which it's happening.
Exactly. And so I'm just thinking about that quote from, I think, Daniel the Advocate, that's just like, it's like a bomb going off every day. I feel like now it's like a bomb going off like every few hours, because it's just really hard to keep up with all of the changes and trying to, and that's part of the strategy, right? If you have all of these crazy haphazard policies, although that's the other difference this time, there's Project 2025. He's a lot more prepared this time than he was the first time around.
Entire blueprint.
Exactly. And so I think, again, that's the big difference between then and now, that he's got a playbook and he's just going down the list and checking things off. I think the other thing that's really different in this moment is just the targeting, it just seems like, of everyone in order to be able to have these mass deportations, to get these numbers. It's like anyone, just someone off the street. Earlier today, my husband sent me this video clip of, I think, an immigrant from El Salvador in New Bedford, ICE, and other people might have seen this. It might have made its round on social media, but basically, like, this immigrant was in his car with his wife, and ICE was just like, "We want to speak to you." And he's like, "I'm waiting in the car until my immigration lawyer gets here." And they just basically used an axe to basically chop the window of the car to open the door and to get him out and detain him. And so the strategies, I mean, this the level of aggression and the level of violence, I feel like is a lot more visible this time than it was under the first administration. And again, the targeting of anyone. I mean, we're seeing in this moment, people being deported without due process, people being detained, visa status is revoked. And I would say that that's certainly different from the first time around. Although certainly in immigration policy, and this is one of the things I write about in the book where I'm about the racialized legal status framework, is that in immigration policy, anyone who's not a U.S. citizen is always been deportable. And I think that for a long time, there'd been this perception that it's only the undocumented who are most vulnerable. But in this moment, it seems like everyone is. And I think that's what's really concerning at this moment, that even citizens could be rounded up and deported to prison in El Salvador without any sort of due process or what have you happening. And that is something I think that is very different and frightening about this time around too.
Yes. One of my favorite people, one of my mentors always says that, public policy is health policy. And you see this reverberating even within our own healthcare system. My colleagues at BMC are talking about, especially, in the past couple of weeks, they're, in primary care doctors, even OBGYNs, individuals aren't showing up for care. They aren't showing up for their appointments. And so how are individuals receiving care, or where are they? But they also don't want to present themselves and be vulnerable and put themselves in a position of where they have to maybe disclose their immigration status and in line, which affects their health.
Absolutely. And I mean, just related to that too, that was something that I found in 2019 as well. And even though that was the third year of the study, it was very difficult for me to recruit immigrant respondents that year of the study compared to the other 2 years because of the socio-political climate. Yeah. So very much the notion of people being afraid, not seeking out care, not going, that was something that I found happening in 2019. And I'll also just briefly say too, in 2016, when I was doing interviews for the second round of the study, it coincided with the 2016 presidential nomination process. And when it looked like Trump was going to be the nominee, I was already hearing in my interviews that in Boston, some immigrants were already starting to disenroll themselves from services before the election happened because of in terms of they did not want to be embedded in the system. So a colleague of mine aside this concept of a system of embeddedness in terms of wanting to remove themselves from the system and, particular public benefits and things like that. So I feel like this has been going on. Certainly, I've been tracking it in my research for almost a decade now, and it's just escalated more and more. The other thing I'll just say really quickly too, before we do open it up, is the other thing that I think is really important that I don't want to get lost in this, and to your point about public policy is health policy. One of the things that happened in 2019 was the Trump administration was trying to repeal and replace Obamacare. Yes. Where we are in this moment with these proposed federal cuts, to Medicaid, the subsidies that people for middle income people can get to purchase coverage in the health exchange is supposed to expire later this year. I'm guessing that the GOP will probably let that happen. So I wrote an op-ed about this in The Hill not too long ago, basically arguing this is the plan to basically get rid of Obamacare without doing an explicit repeal. They're just going to fiscally starve it to death. But there's been no discussion of what we're going to replace this with when all of these people lose their coverage. At least in 2019, there was some discussion of trying to replace it with something, and I haven't heard anything about that with all of these proposed cuts, and that's also pretty frightening.
It's very frightening, especially, a lot of my work is in Medicaid, and when you hear billions of dollars worth of cuts to a program that, for me, serves nearly 50% of the births here in the U.S. and serves our most vulnerable and our most marginalized populations. And it's like, where do these individuals, where are they supposed to receive care? How are they supposed to interact with a health system that doesn't have any support for them?
Absolutely.
Yes. So I will open it up to Zoom and also the audience. I'm trying to see the most effective way to do this. So if you do have any questions for Dr. Joseph, please. Oh, thank you so much, Stephanie.
Just one point of information for everyone. You were talking about where we stand now with people being just dragged off the streets and there's no guardrails. 420, which is the day he wants to do his insurrectionist act, use that, or martial law is Hitler's birthday. So, and for anyone who doesn't know that, if that's not if you talk about signs or their signs, that's 420. We all might think it's just being stoners. No, so that's done for a reason. Okay, there's a lot of other things I could say about this. I'm going to say some more. It's the days of, I'm a lot older than I look. So anti-war demonstrations, Summer of Love, and then we had the Days of Rage. I'll say no more.
Thank you so much for your talk. In your framing, you talk about macro, meso, and micro. And in the migration literature, a lot of folks were increasingly paying attention to like these nested contexts and thinking about the federal, state, and local level. And I'm wondering, some of that debate has asked us to think about the lay person's experience and how they very often flatten these nested levels, and it makes no difference to them whether the federal government is saying this or state or local. And so I was wondering the degree to which the federal level is now eclipsing anything that's happening, because there was a sense, especially 10 years ago, that it was better to be a sick, undocumented migrant in Massachusetts than it was potentially in Florida or Alabama or Texas. And it seems like from those interviews that was becoming less true. As both activists and researchers now, should we be focusing all our attention on this macro or kind of parent federal level? Does it even matter if a state is taking a strong stance or if a local context is more receptive than other? And yeah, like how do the respondents that you engage with think about this, and then how do we as researchers think about it?
Thank you. That's a really important question. Absolutely, especially in this moment. I would say that in terms of thinking about the research that I did, and even just thinking about under the first Trump administration, that there was very much an attempt in Massachusetts to do whatever could be done at the state level to try to maintain healthcare programs and healthcare access, to try to think about policies that could try to stem, I guess, the tide or the impact of what was happening in the federal level. And another way that happened in Massachusetts too is that the then Attorney General, who's now the governor of Massachusetts, Maura Healey, was a part of countless lawsuits against the Trump administration. And so I think that, at least at that particular time, that at the state level, there was very much a recognition that we need to do what we can in Massachusetts to shore up our healthcare system where we were able to, and to do what we can for the residents of this state, and if there are ways to partner with other states doing similar work to do that. I think to some extent that is still happening, but I think because of the rapid speed with which everything is happening, coming from the federal level at this moment, it makes it hard to be able to effectively organize around some of those efforts and those actions. And I think the other thing too is because everything just keeps changing, or the context keeps evolving. And in terms of what we're seeing with the cuts from DOGE, but also these proposed cuts around Medicaid and things like that. And I write about this in the book, that, if that goes away, that's going to destabilize the Massachusetts healthcare system and other healthcare systems. So even though the state of Massachusetts had this reform in place that was a model and that was able to hold the line under the first Trump administration, if you don't have the federal funds or you can't produce them in some way to make up for that huge loss, it's really a challenge to figure out what you can do at the state level, unless, I guess, the millionaires and billionaires in the states decide, you know what, you can go ahead and tax us more to make up for that difference, or we'll make a donation or something, or what have you. But I just feel like in this particular moment, with the way that federal funding is being used as this bargaining chip, and, you're asked for one thing today and tomorrow the list of demands could change, it really makes it hard to organize, even if you wanted to try to go think about federal level actions. But I still think it's important for there to be some resistance in whatever ways that there can be. And I think at the micro level is where I think a lot of that action is going to happen at the grassroots level. People getting together, people talking, people figuring out what can we do within our town, within our city, within our state to figure out how we can resist and try to make up for some of these, I guess, deficits that I feel like are definitely coming, even though we don't know when. So I feel like I'm at a loss for words. In the book, I had policy recommendations in the concluding chapter, but I, made my final edits to the book manuscript before the election happened. And all of those policy recommendations I made, I don't see there being the political climate for that to happen. Maybe some of it can happen at the state level, but certainly at the federal level, I just don't see those things happening, unfortunately.
Excellent question.
Thank you so much for this very rich and interesting talk. I'm really curious about, you had 3 classes of interviewees, and you had your practitioners, your doctors and health professionals, and your advocates, and then the immigrants themselves. I'm curious about whether or not the class of health professionals talked about what the possibly, and this is a little bit dark, but the outcome will be if the worst happens. Mm-hmm. And whether or not that's intentional, actually. Because, with, you mentioned the Project 2025, but there's also a whole political theory around depopulating this country in a certain way. Mm-hmm. And I'm just curious about your thoughts about that, if any of that was alluded to in terms of how to change the population through basically disemboweling the healthcare system in Massachusetts. And then the second thing that goes along with that in terms of that is the epidemiological implications of having a lot of sick people and what they say. So I am really curious about the meanings that came out and other implications from it.
Yes. So in terms of thinking about the providers that I interviewed, many of them, I would say they did not allude to, what you just talked about in terms of sort of winnowing out the population or just letting people get sick. But they did talk a lot about sort of the health outcomes that they saw among, the immigrant patients who were still coming in terms of chronic illnesses, a lot of mental health, depression, stress, anxiety. In the Brazilian community, when I was doing some of the interviews, there had been a high number of suicides. At least what I was hearing on the ground in the research was that people thought that much of that was related to the climate and just how difficult it was becoming for people to live in this context. So there was discussion in the sense of sort of these health outcomes and concern about if people are not getting the preventive care that they need now, that this is going to lead to more severe health implications later. There was also concern about how not going for care could also be a really big health issue for people in terms of the fear whenever there were raids or threats of raids or on WhatsApp in a lot of the immigrant communities, people would send out messages, ICE is on the highway, don't drive this route at night, those sorts of things. And so those sorts of messages and those concerns led to people not getting care, and doctors would talk about the implications of that. And again, I'm reminded of the quote from Javier, the health advocate, that talked about a dip in people getting services and sort of the public health implications of that. And in terms of your question, I mean, if there is this disemboweling of the healthcare system, it would definitely lead to what you suggest in terms of if people are really sick, if people can't get care. We're also dealing with measles outbreaks and diseases coming back that we thought were eradicated because of, people not getting vaccinated. Yeah, it is a very dark time. And maybe that is part of the Project 2025 playbook in terms of what you say about depopulating the country of certain groups so that other group or one particular group will benefit from that. But at the same time, COVID and public health implications, they spread regardless of who, you are trying to target. We certainly saw that with COVID. And even in terms of thinking about, I guess, all of these funding efforts, federal funding cuts, a lot of the people who are going to be affected by that, who are being affected by that, are people that voted for him in states that overwhelmingly voted for him, that racially identify or classify as white. And that's the segment of the population he claims to want to uplift, or that they want to be having more babies or populating. And so I think going back to, one of the things that I talked about a little bit earlier, that, even though policymakers may have these ideas in mind about what they want to happen with particular policies, once things are implemented, you really don't know what some of the adverse consequences are going to be. And so if that is the intent and they're thinking they're going to affect certain populations, there are certainly going to be some unintended consequences to that as well, that will affect, again, populations that they might not intend or want to be impacted by these policy changes. That's sort of my thought.
Maybe that's the play all along.
Maybe.
Giving principles of eugenics.
Hello. First of all, it's a superb piece of research. I really, really enjoyed it. Your talk as well. I have a question about the process of interviewing. There's a tension involved in there between being the objective interviewer and being sufficiently empathic to encourage people to reveal themselves. Neither of them is the perfect way to go. So I want to ask how you dealt with or struggled with those two urges or impulses, and how do you think just the way, the tone of voice that you use or the phrasings that you use could elicit a response that might be different if someone used, or if you used, a different phrasing or a different tone of voice. How did you struggle with that?
Absolutely. That's a great question. And I'll start by saying that even before I started the interviews for the project, I spent a lot of time just going around Boston to different events and things like that, immigration and healthcare related events, so that I could start to get a sense of what was happening on the ground. And that was how I was able to connect with some of the organizations and with some of the communities. And so I think that was like the first big piece of starting that process, trying to understand, getting to know the communities before I even started doing the interviews. And so once it came to doing the interviews, one of the things that I'll just say in terms of thinking about the research design was each interview for each stakeholder group was a little bit different. For the immigrants, I'll just focus on those in the interest of time. One of the things that I did, I often started with just tell me a little bit about yourself. How did you decide to come to the United States? Can you talk to me about where you were from, your home background? Do you talk to family members often? So that was kind of a way that I tried to break the ice in terms of getting people to sort of open up a little bit about home and sort of how long they've been in the U.S. and what their experiences have been like. And then from there, I would go on to starting to ask questions about people's, how people racially classified themselves using either U.S. categories or an open-ended classification. I asked people about documentation status by asking, when you came to the U.S., did you come with any sort of, visa or anything like that? And then I would ask, since you've been in the U.S., have you been able to acquire one of these different statuses? And so I didn't explicitly ask people if they were undocumented. So, even in terms of, your question, being very strategic and thinking about, sort of how questions are asked. And most of the interviews with immigrants were done in another language. So I definitely, before starting the research, I asked primary speakers of those languages to review the protocol to ensure that, in terms of what I'm asking, the language that's used, I want to make sure that this doesn't come off the wrong way, because I wanted to be very careful about that. And then I think the other thing that was really important was I really just tried to give people space to be able to share as they felt comfortable to. I let them know, if there's any questions you don't want to answer, you don't have to do that. If you want to stop or pause at any point, I'm open to doing that. And so I tried to make people feel as comfortable as possible during the interview. And in terms of going back to the language piece, certainly, I think my ability to be doing those interviews in their preferred language helped make people feel comfortable enough to be willing and open to sort of sharing some of the more troubling things about their experiences with me. In terms of towing that line, sometimes it was difficult, as in the example that you asked about with that particular Brazilian respondent who, after the interview ended, I shared resources with him. But in that particular moment during the interview, I didn't want to sort of just not necessarily impact the flow of the interview, but I wanted to give him the space to be able to express himself. But I also was making a mental note to myself that once this is over, I am aware of some resources. I can share them with him. And so that was what I tried to do during interviews. I really tried to give respondents the space that they needed to speak and to share what they wanted to share. But also, too, if need be, at the end, if there were resources that I could point them to or be like, there's this organization where you can get help applying for coverage in Portuguese or Spanish, call them, look up the website. So I felt like that was the way that I really tried to balance and be mindful of that, too, of that very delicate balance, certainly with the immigrant respondents.
Did you have any people who were, at least initially, very suspicious? And if so, how did you deal with that?
Yeah, so I would say that I would say probably more of the suspicion was in 2019, where I had more difficulty recruiting people, recruiting immigrants for the study. And I certainly had a couple of respondents who were not comfortable with me recording the interview. And that was the first time in the whole study that had ever happened, where people were just like, I will talk to you, but please don't record me. And so those people, they didn't necessarily express, sort of skepticism about me. But I think in terms of the moment that we were in, they were concerned about what would happen with that data, which they were very right to be concerned about, as much as I did as much as I could, to sort of de-identify my data. And, if the government today said, we want your data, it's like, here, it's all de-identified, you can have it. But in that particular moment, that's, those respondents were right to be, concerned about that. And I explained to them, I'm not going to do anything with the data, but if you're not anything, that could put you in a more precarious position with the data. But if you're uncomfortable with that, we don't have to record. So I think it was more probably a reflection of sort of the heightening socio-political climate than, sort of skepticism of me in terms of me doing the research. And I think part of that is probably related to the fact that I had been very much embedded in a number of the communities for, at that point, almost a decade. And I used snowball sampling as well, too. So, once I interviewed people, I would ask them if there's anyone else you think you would want to speak with me about their experiences, feel free to send them a flyer or have them get in touch with me. And so I think that probably helped as well, if once people had a positive experience sharing the interview or doing an interview with me, they were comfortable to recommend other people. And I even had some people say, I haven't really been able to talk about this with anyone, so I'm glad to have this space to do this in this interview setting. So I think that's probably the other piece that's important, that a lot of times people are carrying this with them and they want an opportunity to share it, but they're not sure when and how. And I think the interview provided a way to do that, especially because of my embeddedness, if you will, in the community, and also with the organizations, that people would say, yes, Tiffany is someone you can you can trust that you can do an interview with. She's volunteered here. She's done citizenship application clinics. She's helped people fill out their DACA forms. And she's, translated and done that sort of work for us. So, and that's why I said the start of the project, of the research, was not the interview process, but spending a year just going and trying to get to know and get embedded in the communities, understand what's going on before I even did my first interview.
Can I add to that question? You re-interviewed 10 respondents. Did you see a shift from the first interview to the second, or was there still some level of?
So I would say, and I'll just briefly mention that for the immigrant respondents, I wasn't able to do any re-interviews because of IRB. And, in retrospect, I'm glad that they were like, we don't think you should be collecting people's information or recontact them down the line. But also when I started the project, I didn't anticipate I would be going back into the field. It was just something that kind of happened. I thought I was going to do research in 2012 to 2013, write a couple of articles, move on to another project. But at any rate, the people that I was able to re-interview, basically when I decided to go back into the field each time, some of these people I had sort of stayed in contact with when I started publishing things from the project. I had them on an email list, and I was just sort of like, hey, this is what I'm doing with the research or what have you. And so they were very much willing to speak with me, again, because I think many of them sort of felt like, certainly by 2019, some people I'd been able to re-interview for 3 years of the project. People very much were looking for an opportunity to kind of be able to begin to talk about what they were experiencing and seeing in their work and wanting it to be out there, in terms of thinking about the interviews. And I think for me, in terms of that re-interview with the quote from the provider who basically was just like, yeah, I feel like healthcare access for my patients has gotten worse since I started practicing medicine and the start of these reforms. Multiple healthcare providers shared something like that. And so when I started seeing that in the data, I was just like, I can't believe I'm reading this, that people are saying healthcare access for immigrants was better before both of these reforms were implemented compared to what they've seen progress in the progression of these reforms over the last 15 or so years. Having done the re-interview data really allowed me to be able to sort of make that connection and to sort of really see that come out in the data. So,
very nice. Well, we're going to end our quick Q&A there, and we're going to conclude our event. I also just want to can we just give a round of applause for Dr. Tiffany Joseph?